to help. And yes, we are going to record the session for some people who wanted to attend but weren't able to come during this time slot. And then we're going to, finally talk about our expansion to all the Atlantic provinces. So before I get into the meat of it, I also want to acknowledge and thank Michelle Lowe for helping to organize this session and reach out to you folks in the sector. Really looking forward to your comments and feedback. I'd also like to give a very sincere thank you to the facilities, the care homes that participated in this research. It was a convenient sample, so people bravely put up their hand, not knowing that Omicron was going to happen just towards the end of our data collection and that we would still be in a COVID situation, and really appreciate your work. So if you're from one of those facilities, you know who you are. Thank you so much for enabling us to continue with this research. So I'm going to show you a very complicated slide, but just wanted to share that our work in Nova Scotia, what I'm going to talk about today, builds on some previous research with TREC, which is translating research into elder care. And they have been doing this since 1908, not quite, 2008. And so they're actually finished while we're talking about wave 1 in Nova Scotia today, that is wave 6 for TREC. So you can see that below, they started off with just 36 facilities. They've expanded to over 90. And then with our new expansion, we're going to be up to 130 different facilities. So it's quite an undertaking. It's a very similar survey that's longitudinal, and then there's so many offshoots that TREC has been able to do that focuses on the quality of life of the residents, does some interventionist studies. So there's one called Inform and one called where they got the care aides themselves involved in making change at the unit level, and then been able to measure that. So this is really all about being able to create system change. And TREC's mission statement is really by developing the innovative and practical solutions to contribute to the sustainable improvement in quality of care, quality of life, quality of end of life for the residents, and as well as quality of work life for their care providers. So there's a real emphasis here on tangible, practical solutions and make change. And so we were involved and used their TREC COVID impact study between October and December. It's some collection in January. And this was an online survey for nurses and managers, but for the CCAs, we administered the survey. So it was still fairly closed-ended approach, but we interviewed them, or we administered the survey typically via technology, via Zoom or Teams, or on the telephone. So what we're really looking at and what's in that survey are these main concepts or domains. So there's staff quality of life, their job, some of the environment, the leadership, the culture of their workplace, their mental health, their decision-making process, their information sharing, their relationship with their work, their job satisfaction, for instance, their demographics, of course, their job experience, etc. And also some of the issues that were related to providing care during COVID, such as managing difficult situations and their level of resilience. Now, I'm not going to share all of these with you today, but we're going to pull out a number of different outcomes to share. The other thing we've been doing is dissemination activities. So each of the 10 facilities that we participated in the study received an anonymized data for their particular home compared to the other facilities in Nova Scotia, and then compared to all of the facilities that were in the project in Alberta and Manitoba. So at the same time we were collecting data in Nova Scotia, the survey was being administered in Alberta and Manitoba as well. We also provided some summary infographics to the homes on the overall sample that were specific to the continuing care assistants and to nurses. We've presented to the ministry and the health authority on a couple of occasions to keep them interested and in this work and finding solutions. And of course, we are writing a number of papers on this, and I'll share a couple of those with you at the end. So who were the respondents? So we had 10 homes in Nova Scotia, 27 in Alberta, and 10 in Manitoba. So we had 266 care aides in Nova Scotia, 144 nurses, and we also had 45 managers. And so that's an important piece that we won't spend a whole lot of time today on, but it is something that we are looking at. So the really big difference, and again, this may be because of the nature of our convenience sample, is that most of the care aides spoke English. That was their first language, very different than in Alberta and Manitoba. So you can see 76% of care aides in those two provinces have English as a second language. It's very common. And in order to be in the survey, they had to work within the same care unit for 3 or more months and had to have at least six shifts within the previous month. So who were the respondents again in terms of age? So interestingly, so I'm going to show Nova Scotia in comparison to the combined Alberta and Manitoba. Our care aides were significantly younger than those in Manitoba and Alberta. See here. And similarly with the nurses, we had younger nurses participated in the study. They tended to be much younger than those in Alberta, Manitoba. Use this. Okay. So we also showed that there were some differences in the number of hours worked in the previous 2 weeks. So Nova Scotia CCAs worked 13 hours more than those in Alberta, Manitoba. The nurses' hours were much closer, but interestingly, the Alberta, Manitoba nurses worked slightly more than Nova Scotia. So now I'm going to move on to health outcomes, and I'll just say, first I'm going to show you just the Nova Scotia data. So CCAs compared to nurses on these outcomes. And then I'm going to show you just the care aides compared to Manitoba and Alberta. Okay, so each of these have two sort of slides that go with them. So let's look at resilience first. So this is a 6-item scale, staff being ability to bounce back or recover from stressful situations. So you see here, the red is low resilience. So even though they have very similar scores and high resilience, care aides have significantly higher likelihood of low resilience compared to nurses just in Nova Scotia. And then when we look at it across the country, so Nova Scotia is has a higher rate of low resilience, but had a slightly higher rate of high resilience. So they're sort of on two ends here as compared to Alberta. In terms of anxiety, This was quite an interesting one from my perspective. So this is talking about, it's a 7-item scale, how bothered staff feel by problems that they're experiencing. So again, care aides had a higher rate of moderate or severe anxiety compared to nurses in the Nova Scotia study. And when we looked at it by provincial comparison, we see that, again, just at that care aide level, Nova Scotia would have 38% would score moderate to severe anxiety on the anxiety scale compared to 12% in Alberta, Manitoba. So I'm just going to say, you know, at this point, we're trying to understand the role that cultural factors may play in this. So we've been looking at some of the instruments to see if there are some differences based on the cultural background, given that a lot of the care aides from Alberta, Manitoba have English as a second language. Another scale we looked at was perceived stress. And this is showing, again, care aides have proportionally higher levels of stress, not a huge difference than nurses, but a little bit. And then compared to Alberta, Manitoba, so this was quite significant, higher levels of stress for Nova Scotia compared to Alberta. Okay. Then on to mental health. So this is different slides. So I'm going to show you, first, let's look at 42. This is the same time. So time 1, 50, the score for mental health. This is a score, an SF 8, I think it's called, but anyway, it is a measure of an individual's mental health. So the lower the score, the poorer your mental health is. So high scores mean better mental health. So at time 1, and that's our time 1, so 43, about 43 score for Nova Scotia care aides compared to about 52 for Alberta, Manitoba. And then, of course, because Alberta, I'm sorry, it should be this one, time 2, 50 compared to 43 here. But compared, because Manitoba has a series of longitudinal data, we can do a comparison of time 1 before the pandemic, just before the pandemic. They had a wave that ended in February 2020. So those data are pre-pandemic, and then our data from 2021 is sort of during the pandemic. So you see there was a slight, it is actually significant, and this is a very difficult scale to actually move. So it's quite interesting for us. It's because we're writing a paper on how did the pandemic affect care aides experience at work. And you can see there is some slight decline, not a whole lot. Again, similarly, the nurses are a little higher than the Nova Scotia care aides, scoring 45 compared to 43, but not a huge difference. So I'm going to move on, and these are going to be work-life outcomes now, and I'm going to start off looking at job satisfaction, right? So this is a 3-item scale. You know, a question would be like, all in all, I am satisfied with my job. So there's, we know that there's been quite a bit of stability across all of the TREC data, the 6 waves, including the one pre-COVID to our time 2 data in the fall of 2021. And certainly we have a lower baseline of job satisfaction in Nova Scotia than TREC has, or Alberta, Manitoba has. So another interesting, I think this is really important because we have a bit of a baseline now. And as we move on, I think that will be critically important for us. So then we get to cynicism. So higher rates of cynicism means that they don't feel their work contributes to anything, that they feel distrustful. So so these are the scores. Again, these are at the same time. So Nova Scotia Aides 54% scored high in cynicism compared to 48% in Manitoba and Alberta. When we look at Alberta at time 1 versus time 2, there is not a very little difference in these rates. And even our differences at time 2 are not significant in this score area. But nurses did have lower rates of high cynicism, which is that's the good thing if you have a lower rate. Okay. So also MBI stands for Maslow's burnout inventory. So that's why it is in the foreground there. So emotional exhaustion means that is measuring a respondent feeling strained or overexerted, both emotionally and mentally. And so we're again showing high levels of the mental or the emotional exhaustion. We're not giving you all the 3 low, medium, and high. We're just giving you the high here so that we can show you this. So this is where there are definitely significant differences between Nova Scotia Aides and Alberta. The Western Aides much higher in Nova Scotia. And time 1 to time 2, it is significant, but it's not, it's minuscule within the Western provinces. And interestingly, the nurses didn't score as high on emotional exhaustion. And then finally, the last MBI indices is efficacy. So this, we're showing lower scores here because lower efficacy is the least favorable. So when you have low efficacy, staff are not able to reach their desired sort of accomplishments in their work. Their work has less meaning for them. It might be, you know, I feel exhilarated when I accomplish something at work. You know, I accomplish many things while on the job. So those kinds of questions would have been included in here. So low efficacy. First of all, there was a decrease in efficacy, meaning that at time 2, they have more of the care aides had low efficacy scores. So there's a concern there from time 1 to time 2 in the Western provinces. And then Nova Scotia has a higher proportion of low efficacy than Alberta or Manitoba. But look at the nurses. This is, again, a huge difference. Much higher proportion of nurses experiencing low efficacy. So feeling that they're not able to reach their desired accomplishments at work compared to the care aides.
So Janice,
Yep.
can I just make one observation? Because
Yep.
in some work I've done in the past, this construct, efficacy, is critically important to empowerment. Yeah. And if we have issues with low efficacy scores, we wonder why we have issues with empowerment.
Absolutely. Absolutely. If you don't feel like you're contributing anything or that you're good at your job, you're not going to feel empowered to make change and to suggest change and to do change and to get involved in all of that. So yeah, no, definitely. Thank you for your comment. So now I'm going to move to organizational context, but maybe before I do that, is there any questions, Pam, in the chat box? I've got two screens and I'm kind of hard to manage.
There was one question that Eric had raised earlier when you were presenting the resilience results. Just wondering if there's any consideration of looking at that by the care aides age and experience. So I said that those will be some of the further analysis that will be done when you work specifically with the care aide data.
Yeah, no, that's a great comment. And some of the work that we will be doing will be trying to control for some of those other variables that we know are unique to that may be impacting on that those outcomes or those results. Yeah, good point. Okay, so I'm going to talk a little bit about organizational context, and this is a real central feature of Alberta's work in this area. So they have developed a or Alberta context tool. So this is measuring what the work environment on all of these different aspects. So in each of these are an instrument with a number of items. So they use the scores from the care aides or CCAs. So they would ask the care aides at that unit level, what is the leadership? They have a range of questions on leadership, a range of questions on what's the workplace culture, how much feedback do you get? Are you working to full practice? Are you able to offer things to improve? So there's a whole host of other questions. These are in red because these are aspects of ACT that are really modifiable. It's kind of, Eric, as you're saying around efficacy, if we can change one thing, it may help to change the way people see or the work environment that they are experiencing. If we can change the culture, if we can, help to be more supportive in terms of leadership. I'm sure you guys all know this. So anyway, in order to get a score, you had to have, because it's done on an average at the unit level, so you need at least 8 care aides to be in that unit and complete the survey to get a score at the unit level within each care home. So it's a clinical micro system that we are looking at, and there's a whole way or methodology that we use to determine what is a unit. If it's a combination of households, if you're in a newer build, it may be that may be the way it is developed. Anyway, so we use this, and it's really looking at way to manage or to quantify, I guess I'm going to say, how supportive, what's the context in which workers are experiencing at their nursing home. And so what TREC has done is they have clustered these outcomes of the ACT into higher homes which have more positive context, higher level context, and homes that have more negative context or less positive, let's say. And so they call them red and green. And so I'm going to show you how we can use this to look at some of the other data. So for example, this is a question that we asked in the survey about leaving tasks undone. So on your last shift, there's a question about, were any of these tasks left undone? And so we also have a question on rushed care as well. So this is presented using units that have more favorable organizational context compared to units that have less favorable organizational context. And this has been published by Jennifer Knopf-Sonata, and with Carol as the senior author. So you can see that, not surprisingly, if you don't have favorable organizational contexts, you're more likely to leave tasks undone, whether that's walking residents, sleep, talking to residents, toileting, dressing, feeding, mouth care, hair, and nail care. So these are just an indicator of how you can use these contextual data to understand what's happening in the facility and how you may want or be able to modify the work environment. And then what we are hoping to do, of course, in Nova Scotia with the introduction of the TREC and what they've been able to do for years in Alberta and Manitoba, is to link these the CCA data, the Care Aide survey data, and this issue around work context with the resident outcomes, right? So so it's at the unit level where the data would be linked. So it's not individuals. It wouldn't make sense that Care Aide to one resident. It's like off the Care Aides that work on this unit. So let's just hypothetically, we threw this out. You got a care home, you have 3 units. One of them has 15 regularly assigned CCAs to that unit. And when we did the survey, we got at least 8 people responded, hopefully more like 12, but and so we get then an average that allows us to do this red and green, or just the favorable versus less favorable versus more favorable. And then we can link at the unit level the outcomes of residents, the resident assessment information that we'll get from TREC. So that may be things around mobility, it may be things around, you know, pain, dysphagia, antipsychotic medication, or use of overuse, misuse, etc. So that's what we're hoping to do. So I'm going to show you the next slide is going to be an article that's talked about the last year of a resident's life in the nursing home. So this was retrospective data, and they looked at their assessment over that full year around the incidence of treatable symptoms. So symptom burden, and how did that connect to the actual workplace context, so modified features of the workplace context. So this is pain, for instance. So just using this example, and this is broken down by the solid lines are persons with dementia. So first of all, you know, perhaps with the RAI, it's someone else's assessment of a person with dementia's pain, but there's a higher proportion of reporting pain in the lower context, lower favorable homes. And in the higher context homes, you have less reporting of pain, and very significant when it comes to non-dementia. So you really see it here that in low context facilities or units, there is, you know, 25 to 30%, over 30% in pain. So these are the number of quarters before death. So going back each quarter compared to those in the high context. So this is where the 2 things, the staff survey and the TREC, can come together, not just with this, a whole host of other aspects in our research.
Janice, just one quick
Yep.
question. I noticed in the abstract, they were using the MDS RAI2.
Yeah.
So I haven't done a crosswalk between LTCF and MDSREI2, which is what we're going to be using here in Nova Scotia. So I was just wanting to flag the differentiation between the two.
Yeah, no, great comment. And I do know that people have already begun to develop the crosswalk at Ki-High. And so these kinds of, symptom burdens, I think they're in both. The issue will be the scoring and making sure if you're comparing to previous data. I mean, everyone is moving towards the LTCF, even Alberta. I mean, they're still at 2.0, but they have in their near future to move towards. Yeah. And so, yeah, so good point, but we'll be using the LTCF for sure. Yeah, Christina?
Yeah, hi. I just wanted to mention that there are some sites in Alberta that are starting to use the LTCF. And so we're going to have to manage this sort of regardless. So it won't be any different in how it's done with the Atlantic Canada data.
Okay, that's great. Thank you. So some of the key messages really from our survey, and you can tell we're just giving you a snippet of some of the outcomes. These were, just keep in mind, these were collected during the pandemic, and it does raise some concerns that we need to monitor and address. Certainly, Nova Scotia CCA's reported more negative health and quality of work-life outcomes compared to the Western care aides. Again, I want to iterate that this is preliminary data. We need to dissect this more. You're right, by age, by English as a second language. All of those things are going to be important to better understand. But in comparison to CCAs and nurses, nurses do report better health and quality of work-life outcomes than the care aides, except for efficacy. Again, something to monitor, be concerned about. So what we're saying, of course, is this is really important to have this baseline data so that we will know what changes may have occurred, what some of these instruments that are funding instruments or educational instruments that are coming down, what difference that might get, and what might interventions, actual best practices in certain areas, investments in those, how that might then change the workplace context, etc. I'm just going to give you a little snippet of a paper on the Alberta managers, because I figured some of you were on the call, may be in fact managers, and I hope you don't look like this. I like Eric's sunshine behind better, but they did a pre-post analysis with managers that has been published. It's a short paper. Excuse me, only 7 pages. If you're interested. Oh, excuse me, I'm gonna get a glass. Big water. So at time 1, they had 87 managers, and at time 2, they had 94 managers. So they did demonstrate that many measures of health and well-being worsened significantly during the pandemic. And their assumption was probably not rocket science to people on the call, but pressures from senior management and health authorities, as well as coming up from staff and families, visitors not being able to access, were creating these challenges. In time 2, the managers had a much higher risk of turnover, which also jeopardizes the care home stability or sustainability. So one of the questions was around whether they thought they might leave in the near future. And so that's written up in this report. Okay. Any other questions, Pam, while I, take a coughing break?
No, that's everything right now, unless someone wants to add a question now while Janice is taking a water break.
So Janice, in that last slide, where we're looking at, there was sort of a net increase of managers from 70, I think it was up to 90, and across the 90 reporting a higher risk of turnover. Was that a question relative to whether they had a contemplation of leaving their role sort of like within the next 18 months to 24 months? And I'm just curious, we don't have that data for Nova Scotia, right? Oh, we do. You're on mute. That's okay.
Yeah, no, it's I have to look up the actual time frame, but there's one intent to leave and how often they think about leaving. So there's two questions, and so we definitely can get that. And yes, we will be. There's been some toing and froing around how we're dicing and slicing this, but we are going ahead and just doing a paper just on the Nova Scotia data. So we'll be looking at that. We only asked the managers and the nurses about their intent to leave. We didn't ask the CCAs. I'm not sure why. We're wondering why now. Hindsight is 2020. Yeah.
I just think we have some other issues happening in the province right now. That data might be extremely useful to us, particularly at the Nursing Homes of Nova Scotia Association.
Okay, well, we can try and feed that to you for sure.
Excellent, thank you.
Okay. All right. So now I'm really happy to let you know that we're going to expand the survey to all of Atlantic Canada. So we just received funding from the Canadian Institute of Health Research to look at an underrepresented, undervalued workforce and understanding and supporting quality of work life in long-term care. So hopefully we will be starting in the fall of 2023. We're going to be in every Atlantic Canada province. We did receive $2.1 million, which is fabulous, but they did cut us almost $1 million, which is not fabulous. So we're still looking. We've had some proposals in to other funding agencies to help. So I'm leading this work, and Carol Estabrooks and Rick from Alberta. Rick Adas runs the Newfoundland Labrador Health Services Research Center. And then Gail Tomlin-Murphy is, of course, VP at research at Nova Scotia Health. So we have 6 co-investigators on board. It's not a huge team, but it's, I think it is representative of our Atlantic region, and we have lots of support from the associations, including the Nova Scotia the Nursing Home Association, the Nursing Home Nova Scotia Association. I don't know. I keep forgetting it, Michelle.
Nursing Home Nova Scotia Association.
Yeah, that's
that's
okay.
exactly what you have there.
Yeah, good. I'm glad I have it right. Anyway, and we're also pleased to have Shanix and the McLeod Group on. Our first convenience sample had less homes that were proprietary, so this will be really helpful for us as well. To have a more randomized, stratified sample. So we're really going to administer this survey. We want to look at the effects of that workplace environment on quality of work life, but we also want to link this survey data to resident outcomes. So to develop opportunities to use that inter-RI LTCF in a positive way, linking it with the staff survey and helping to build, this is our big one, is building capacity in our region to be able to analyze these data and work with the sector to build responsiveness to real tangible practical considerations to help facilitate improvement in the sector. So So we'll be, of course, PEI is not, doesn't have Inter-I as of yet. There is some thinking around that. Of course, I'm on I'm on their expert panel during COVID of long-term care, and it is one of the recommendations. I can let you know that. But we want to be able to, you know, as I said, expand this. We're going to be able to really focus in on establishing a really solid baseline, and hopefully then use that to look at different interventions within health authorities or regions, and be able to do that pre-post measurement of change with following an intervention. So in order to be eligible, it needs to be a standalone facility, have 90% or more of the residents age 65 or older. And we're aiming for 25% of homes in each province, but we will be oversampling in PEI and Newfoundland Labrador. And we're stratifying that by health region, by size, and by ownership model, depending on the province, because of course a couple of provinces don't. Yeah, and the time frame is fall 2023, and I see Michelle has her hand up.
Yeah, well, you already answered one of my questions around a regional representation, but the other question is, we have within our membership, for instance, that have within their license some level of RCF beds that were part of their nursing home license. So will that make a difference in terms of your selection process?
I think that as long as, I mean, if we can separate them out into units, so if there are separate units that are long-term care level 2 or 3 from the RCFs, then I think we're able to include them. That makes sense? And I will say, just a clarification, because the 10 homes that were in the 2021 study that I just reported on, we got further funding from the sector to repeat that in the fall of 2023. So they will definitely be included. In addition, we will randomly select another 20 facilities based on our sampling strategy. Some of those 10 may end up being in that 20, right? So instead of 30, it looks like we're doing 30. Well, it might only be 27 or 26, or, you know, depending on the randomness of the selection.
Janice, sorry,
Yep.
I raised my hand and be very polite, but I don't see a hand on the bottom of my screen anywhere.
That's
So
all
I
right.
apologize for interrupting.
No worries.
To the last slide, though, one of the things that I think is interesting, and I don't know if there is any plan to kind of move in this direction or not, but to me, an awful lot, when we talk about quality of work life, an awful lot drives to structure. And I'd be interested in knowing how many of these folks that are reporting, you know, less than desirable outcomes in terms of quality of work life actually have quality of work life programs. Are they funded to have quality of work life programs? Like I think it's great to talk about quality of work life, but the sad reality is, particularly here in Nova Scotia, we get no funding for that. Virtually nothing. And so unless we're somehow magically creating these programs internally between our four walls, it isn't happening. So I'm curious to know whether or not there can be any kind of correlation between, you know, the results and whether or not structured programs are in place to support quality of work life.
That's a great question. We do a facility level survey, but I don't believe we would get into the programming at the facility level, but that's a really interesting idea to look into for sure. Yeah, good. So I'm going to just, you know, having you here is wonderful. I'd love to get your sort of insights too, in terms of, you know, what some of the challenges. I'm going to give you some of what I think the challenges are with this big expansion of another 53 homes in Atlantic Canada. I think, you know, that there's the first thing we have to do is get consent from the homes to participate. And, you know, I know there's lots of competing responsibilities that administrators and staff have. We are trying to mitigate that by funding some backfill for the CCA's participation in the project. There is some stipends that go to each of the homes. The next challenge is then to recruit the staff to participate. And, you know, I am well aware of this challenge of another survey. What does it ever do for us? And so we're really trying to get messages out to those homes that have participated and also to the wider sector about some of the value. Each of the facilities will receive an individualized report. We can also do other things. I know that there's a huge emphasis on integrated knowledge translation in this project. So hosting regional type of meetings around ways to improve, like what some of the situations are and how can we help to improve or modify that work environment. We always are very cautious of ensuring confidentiality of both the participation of the home as well as the staff. And I don't know about, we will need, I think, 4 quarters of inter-RIDE data before we can use it. So again, I'm not sure that will all be available to us. There's also lots of opportunities, though. I thought I better end on the positive note. You know, as I said, you'll get a unique report provided to the senior leadership about the survey results. You'll have that opportunity to compare across provinces, not just Nova Scotia and Alberta, but Nova Scotia, New Brunswick, Newfoundland, and we have very different models of delivery, right? Like Newfoundland is more heavily weighted with nurses and LPNs. It's a public, almost all public. PEI is half and half, public and not for profit. And then, you know, and then Nova Scotia, we have the most mixture of ownership of any of the provinces. So that may be of interest as well. We'll hopefully be able to identify some of these modifiable characteristics and really create some spaces where for us as researchers and knowledge users can come together and help to identify some priority areas for intervention. So those are what I think are some of the challenges and opportunities, but I am very interested in hearing what you may see as additional challenges. How can we, you know, really authentically mitigate these? What would it take for your home or Nova Scotia? How do we engage other homes in Nova Scotia? You know, we're in this to really, I'm excited because it's providing that evidence that we can then use to go, or you can use to go to those funding agencies or government to provide support for this workforce and for the residents as well. So I'm very open to hearing from you. What should we avoid at all cost? Like, open to some advice. So thank you.
Hi, Janice. It's Ray Pushy.
Hi.
I do apologize. I know when I was involved with the one at Tinamira, I got